Welcome to this year's 6th Anne Klibanski Visiting Lecture Series. My name is Louisa Sylvia, and I'm the Director for the Office of Women's Careers within the Center for Faculty Development. In today's session, our very own Dr. Lauren Brenner and VA Boston Healthcare System's Dr. Johanna Thompson-Hollands will be talking about continuum of trauma-related assessment and treatment and service members and veterans. And just a little bit about the Anne Klibanski Visiting Scholar Award. This was started right at the beginning of the COVID-19 pandemic, as we noted that the pandemic was disproportionately affecting women. It was making it more challenging for them to be able to leave their household responsibilities to do things like give talks and write papers and do other aspects of scholarship. So we developed this Anne Klibanski Visiting Scholar Award to support their scholarship more virtually through these visiting scholar lecture series, and also by helping to create collaborations and networks with other institutions. The award is in honor of our president and CEO, Dr. Anne Klibanski of MGB. She's the former director, actually, of our Center for Faculty Development, and has a very deep and rich history in doing clinical research here at MGB as well. So it was great to honor her and this award in her name. These were our scholars for 2020 to 2021, our class of 2021 to 2022, and then our current class 2022 to 2023, and you'll see Lauren there at the top. So I mentioned this, well, actually I've mentioned that that our applications are currently open, and they're only open for a little bit longer, so please spread the word now. So we're looking to create our next class for 2023 to 2024. And so please reach out to myself or anyone in the CFD if you have any questions, and please note the application day of Monday, May 15th. But it's a wonderful opportunity to support women faculty across the hospital. And so please do consider applying and encouraging individuals that you know who could benefit from this to apply as well. These are the champions. You'll see me there. I'm thrilled to be championing Dr. Lauren Brenner today and to be helping her to network with the Boston VA with Dr. Thompson-Hollands today. So I mentioned this briefly, which is a lecture series. This is part of the AK Scholar Award. And again, that's the part that we're doing today is this lecture series, again, bringing together someone from MGB with somebody who has sort of an overlapping interest at another organization to, again, help to collaborate and network across institutions. And today, you'll see the Boston VA logo highlighted there. All right, so first, I'm going to introduce Dr. Lauren Brenner, who's a licensed clinical psychologist with home base, which is an MGH and Red Sox Foundation program. Her research focuses on establishing best practices for psychological evaluation and treatment of special operations forces and community service members and veterans. Dr. Brenner is an instructor of psychiatry at HMS and is a credentialed certified brain injury specialist through the Brain Injury Association of America. And after her, Dr. Johanna Thompson-Hollands, who is a clinical psychologist, will be speaking. She's a staff psychologist in the National Center for PTSD at VA Boston Healthcare System, an assistant professor of psychiatry at the Boston University Chobanian, and I'm probably not pronouncing this right, Avedisian School of Medicine. Her work focuses on the role of social work and the treatment of psychopathology, particularly interventions for veterans with PTSD. She's received multiple federal grants to support this work and is currently conducting a multi-site clinical trial to test brief family interventions that she has developed within the VA. So I really look forward to hearing more about that work today. And with that, I will pass the baton over to Dr. Brenner.
Thank you so much, Louisa. I'm going to go ahead and share my screen, and I'm going to start. All right. So today I am going to be discussing behavioral health approaches to transdiagnostic care with the Special Operations Forces community. I have no conflicts of interest to disclose, and my learning objectives are to provide an overview of common presenting concerns and psychiatric observations in Special Operations Forces service members and veterans presenting to a comprehensive brain health and trauma evaluation at home base, and then describing recommendations for providers working with the Special Operations Forces community. So the Special Operations Forces community, so SOCOM as it's now known, the U.S. Special Operations Command, is comprised of all branches of our U.S. military. So there are Special Operations Forces members within our Navy, Army, our Air Force, as well as the Marine Corps. And the top five tier one units in the United States military are our U.S. Naval Special Warfare Development Group, also known as SEAL Team 6. Some of you may have heard about our Special Forces community recently, as they were heavily involved with the humanitarian crisis over in Sudan and the evacuation. Delta Force, the 24th Special Tactics Squadron, Intelligence Support Activity, and the Army Ranger Regimental Recon Company. The mission of the Special Operations Forces Command is listed below, and these individuals are exposed to greater training demands, greater number of combat deployments, greater lifetime combat exposure, highly kinetic missions, which greatly increase the susceptibility or vulnerability for a brain injury or a traumatic brain injury, TBI, and additionally, a higher risk of psychological traumas inherent in the greater training demands and greater number of combat deployments. So who are these individuals? From training to team, there is a fairly rigorous selection process. For example, for a SEAL who attends approximately 2 years of schools and training, the graduation rate is approximately 1%. Most of them have served in the general purpose forces and have attended a number of schools. For example, there are a number of training schools that you'll hear special forces attend. For example, BUDS, which is the basic underwater demolition and SEAL training, SEER training, or survival, escape, and evasion and recapturing training. So they enjoy games which involve problem solving. They're athletes. And they find that social support from friends within the SOF community has been related to lower mental health outcomes of depression and PTSD. However, they've found that higher levels of unit support have an inverse relationship on symptoms, which points to the potentially negative effects of seeking and getting support for work-related stressors within one's work environment. So some potential obstacles to receiving care. In a study of 5 VA polytrauma rehabilitation centers, a comparison was done between Special Operations Forces personnel and conventional forces, utilizing cross-sectional retrospective analysis of the health comorbidities interview and self-report questionnaires. And what they found, consistent with what was reported before, is that these individual Special Forces service members have more combat deployments, more years of active duty service, more likely to be active duty at the time of their traumatic brain injury, which is more likely to be mild and caused by a violent mechanism. They're experiencing a greater number of prior head injuries and a higher number of physical and medical comorbidities. They're demonstrating significantly higher PTSD and neurobehavioral symptom inventory scores, which measure vestibular symptoms, cognitive impairment, as well as emotional symptoms. And interestingly, within the special operations community, only 9% utilize mental health services within the past year. So at home base, we have a 4 to 5 day comprehensive brain health and trauma evaluation program designed for the special operations forces community. And this image demonstrates the approach that we take to our multidisciplinary evaluation. When I meet with individuals, I'm meeting with them for a 90-minute session plus an additional feedback session, utilizing the CAPS, the clinician administered PTSD scale, as well as the DIAMOND, which is a structured diagnostic measure of other psychiatric presenting concerns. And so what we're looking at with this image is, in terms of our evaluation, we're really determining what may be directly attributed to the injury someone has sustained, what may be related to pre-injury factors. As I mentioned, many of these individuals are athletes. Many have experienced childhood exposure to trauma. And when we talk about the post-injury factors, how are we addressing the occupational return to work, as well as social factors? So in terms of the breakdown of diagnoses, this is based on utilizing the CAPS and the DIAMOND. And what we have found with our population specifically that have come in for evaluation at home base is approximately a third that meet diagnosis for PTSD. And this is fairly consistent in what has been found in the general purpose forces, which is different from what has been found in other studies of special operations forces. As I mentioned, though, many other studies have utilized self-report, whereas we are utilizing structured diagnostic assessments. In terms of the other specified trauma and stressor-related disorder diagnosis, what we're looking at here is chronic exposure to traumatic events with chronic stress, with individuals showing symptoms of what appears to be PTSD, but not meeting full diagnostic criteria, as well as moral injury. In terms of adjustment disorder, this diagnosis comes up when we're looking at individuals who are dealing with oftentimes transition from one part of their career to another, transition to retirement, dealing with family stressors between deployments, as well as dealing with the impact of health-related concerns. So this data is also based on the CAPS that we were using for the diagnostic assessment. So in terms of the symptom clusters, when we look at cluster B, we're looking at the re-experiencing symptoms. Cluster C is our avoidance symptoms. And cluster D is going to be the negative changes in mood and emotions that occur. And our cluster E is hyperarousal symptoms. As you can see, we're seeing a significant number of negative changes in mood and cognitions, as well as quite high rates of hyperarousal as well in terms of the severity of symptoms. As you can see, the range of scores on the CAPS in our sample range from 19 to 50. So we're looking at a moderate PTSD population. So there are a number of observations that we have been able to glean from conducting qualitative interviews with these individuals, a few that I'm going to highlight today. The first being that these are individuals with chronic exposure to trauma with limited breaks in a number of different environments. They often report having difficulty managing in low stress environments because they have acclimated to very high demanding training and deployment cycles. When we talk about specifically PTSD symptoms, the re-experiencing symptoms, many of them report that they are not experiencing intrusive memories and thoughts, right? I want to be thinking about what happened. I missed the action of what I experienced when I was on deployment. There are various ways that avoidance emerges. It could be compartmentalizing. Humor is a very common way that we're seeing avoidance, as well as over-intellectualizing. So really minimizing the impact of emotional symptoms. And then just to highlight on this page, there are a number of different changes and symptoms that are reported as it relates to mood, relationships, feeling disconnected from others, anger and irritability. Anger is a very trained tool for these individuals. Having difficulty identifying what is meaningful and what is valued is something that is prominent when we're working with these individuals, clarifying what is a military value versus what is a personal value. And then I'm going to jump ahead to talking about barriers related to care. So in terms of patient barriers, we often see stigma. Approximately 45% of individuals reported that they would not seek mental health treatment due to negative career consequences in a study. There's often a discouragement from reporting symptoms, as well as between patients and providers. There can be assumptions that certain symptoms may equate to a specific diagnosis. For example, people will report that they're avoiding crowds, but we need to clarify, is that related to PTSD? Is that related to general anxiety? Is that related to the impact of a traumatic brain injury someone has sustained? There's difficulty trusting providers within this community, and there's also a tendency to seek a quick fix or a silver bullet. These are very high-performing elite individuals. And in terms of systematic factors, there can often be provider shortages, as well as with the frequent deployment and training cycles, insufficient time to engage in a full protocol. So I'm going to skip over some of the approaches and talk about recommendations for providers. It's important that we're utilizing the language, including terms such as PTSD. It's important that we understand key operator terms, as I mentioned, BUDS, SEER school, and understanding key events in the community. For example, there was an event in 2011 in Afghanistan, Extortion 17, in which 37 SEALs were killed in a Chinook helicopter that was shot down. That is an important date for many of our individuals who come in. Understanding the chronic exposure to trauma, use of motivational interviewing tactics to really meet these patients where they're at and being mindful of one's own judgments, assumptions, and knowledge about the Special Forces community. One of the key tenets of special operations is that humans are more important than hardware. So we really emphasize this, the importance of patient-centered care. And then additionally, given the high rates of co-occurring TBI, we really are emphasizing the importance of practice, repetition, utilizing multiple modes of presenting information. And with that, I will stop.
All right, thank you, Dr. Brenner.
Thank you.
We'll have Dr. Thompson-Hollands up next.
Yes, thank you. I'll go ahead and share my screen. Okay. I'm happy to be here with you this afternoon, talking about family-inclusive PTSD treatment for veterans. My hope is that after Lauren's nice setup of some of the things that folks are bringing when they present to care, then this can be something that might inspire you to take a particular approach to that care by weaving in family members in a way that can be very helpful. I'm going to be starting with an overview of some of the potential benefits of family involvement in PTSD treatment. Next, I will be talking about what we know with regard to veteran and family member interest in family involvement. And then I'll be ending with some specific recommendations for how you might approach involving family members in care. I do want to acknowledge that the views that I'll be presenting today are my own and not those of the Department of Veterans Affairs or the U.S. government, and I have no conflicts of interest to disclose. I also want to acknowledge that while I will be talking a lot about veteran-focused data, both because of the setting where I work and because much of the research that has been done on family-inclusive care has focused on veteran and service member communities, a lot of the principles that I'm talking about here would likely generalize to a civilian population as well. So like all mental health disorders, PTSD doesn't just affect one person. Our patients, often come to us alone, but they are people who live in the world, who have families and friends and coworkers and all of these things. And we know that there is an interplay between social support and PTSD severity. There's been a great deal of research looking at the potential protective effect of social support that might be present at the time of a trauma, as well as, unfortunately, the negative impact of PTSD symptoms on relationships. And how that can be detrimental over time. And a couple of meta-analyses now have indicated that linking between social support and PTSD symptom severity is even more robust among veterans and service members or people who've experienced a combat-related trauma. So for folks who are working with those communities specifically, it's especially important to consider how might we harness these social features in order to enhance our treatments. So there are three key kind of pathways that I think about when I think about how family members might impact a course of treatment for an individual with PTSD. The first is that families are a key motivator for treatment initiation. Often when veterans come to our clinics, they will talk quite a bit about the impact on their social functioning of the disorder. So, they're not the parent that they want to be, they're not the partner that they want to be, and those kind of functional deficits can be even more upsetting to them than, the burden of symptoms themselves. Additionally, family members are sometimes that sort of little bug in the ear saying to the person, you should talk to someone. I think you seem different since your last deployment. The VA can help you, that kind of thing. So they can be kind of the path that leads veterans to care. We do have some evidence that family environment is actually associated with the efficacy of our treatments, specifically that veterans that are living in a family life that is very critical and hostile. In those situations, our exposure-based treatments seem to be less effective. So it's important for us to understand the context that folks are coming to us from, because that might be kind of a hidden variable that's undermining our care. And finally, we're starting to accumulate some evidence that certain types of family attitudes or even brief types of family involvement can substantially reduce dropout from individual trauma-focused treatments. That's very important. Dropout, from PTSD treatment for anyone is a big problem, but especially among veteran and service member communities, it's much more acute. So anything that we can do to enhance retention in treatment is going to be really, really important. People can't benefit from our care if they're not attending the sessions. And so families can be sort of our partners in helping our patients persist in treatment. So I think one thing that comes up when I talk to folks about family involvement for veterans specifically is a concern about willingness, especially on the part of the veterans themselves. There's sometimes an assumption that veterans, either because of reasons related to stigma or military culture, will not be open to having another person involved in any way in their care, that they won't want to disclose that they're getting mental health treatment, or they won't want to share any sort of detail about a diagnosis or the trauma event itself. And so I have some encouraging news to report, which is that a couple of different surveys now of veterans receiving outpatient care in the VA have shown that 80% are interested in greater family involvement in their mental health care, which is incredible. That's a very large majority. The nature of those particular survey studies doesn't allow for a ton of nuance with regard to what the veterans were interested in. So I'll be talking later about the importance of exploring, in specific, what an individual veteran or other patient is interested in with regard to family involvement. But I think that 80% number is really striking with regard to kind of a threshold that we might be reaching of folks that are willing. And additionally, multiple studies that I and my colleagues have conducted both affirm that high level of veteran interest, but also affirm the family member interest. It's really striking to me whenever I do qualitative or survey work with family members, how grateful they are for any opportunity to really concretely and behaviorally indicate their support for the veterans' care. And attending a session with a provider is a great way for them to do that. And they're very happy to have that opportunity and to gain the information as well and learn something. In somewhat less positive news, another study that a colleague and I conducted last year, or published last year, we looked at a sample of over 1,300 post 9/11 veterans, all of whom were receiving mental health care in the VA. And we found that only 8.4% of them had had even a single family inclusive visit over the prior 5 years. And so if we think about that 80% interest number and then coming down to about 1/10 of that actually receiving family inclusive care, that's not such a great proportion. And so we want to understand and be thinking about what are the points along the way where we might be losing people. There could be features related to the patients, the providers, the systems that contribute to veterans not receiving family inclusive care. But I think it's really important to be attentive to that and try to shift things in such a way that more veterans have the option to access these types of services if they wish. This particular quote comes from a study that I did running some qualitative interviews with clinicians at different VAs around the country, talking to them about their approach to family inclusive PTSD care, what was working, what wasn't working, barriers, things like that. And this particular clinician was someone that I spoke to. They had accepted a leadership role in their local PTSD clinic, and in their sort of clinical orientation, they were very motivated to have a family inclusive element. And so they had really revamped a lot of the clinical procedures within that clinic to emphasize family involvement and make it more of kind of the mainstream approach. And so I just love this quote. They said, there are different ways to approach inviting families in. I mean, one way to approach it is you flip it and basically say the standard of care is that family members participate in treatment unless there's a reason why they don't. And so while, of course, we're never going to mandate family involvement, and there are going to be times where it's not appropriate or clinically indicated, I think it's interesting to think about this as a framework and to think about potentially in settings where you might be working, is there a way to make family inclusive treatment feel like more of the default, feel like less of something that patients themselves might have to seek out or individual clinicians have to remember to ask about, and instead to have it be, woven into the day-to-day practice of the setting. So how might you do that, right? There's a couple of different pathways, a number of different pathways to working with families. So I'm going to present a few different options just as a sampling of approaches that you might consider. So the first is cognitive behavioral conjoint treatment for PTSD, or CBCT. If you have heard of any structured family inclusive PTSD treatment, it is almost certainly CBCT. It was developed a number of years ago by Candace Monson and Stephanie Fredman. It's a wonderful protocol. It has a nice dual focus on PTSD and relationship issues. Sort of takes the onus off of a single identified patient and instead kind of joins the dyad in, addressing these problems that are, shared across both of them and they're both kind of struggling with. It is a fully dyadic treatment. So both members of the dyad attend all sessions. And I keep emphasizing dyad rather than couple. I think sometimes people think that CBCT is only for romantic couples, but actually all types of dyads could be appropriate for CBCT. It doesn't have to be romantic couples. It is a 15-session protocol, which is quite lengthy for two, people to commit to weekly sessions. Some groups are experimenting with a briefer 8-session approach, but the sort of standard delivery is 15 sessions. So that is, I would say, the major drawback is just the time commitment on the part of the dyad. If you were interested in delivering CBCT, sort of the best practice is to pursue formal certification in the program. Within the VA, it's part of a rollout of our evidence-based treatments. So that's how many folks get training. But I know that Dr. Monson provides community trainings that can be accessed outside of VA settings a number of times a year, and she's an excellent trainer. But it's, it's something of a complex protocol. So I do recommend getting some formal training or being supervised by someone who has had good quality training as well. Another approach is a protocol that I've been developing and testing for a number of years, the brief family intervention, or BFI, for PTSD. This is not a standalone treatment. It's meant to be delivered as an adjunct to either cognitive processing therapy or prolonged exposure. So, the BFI is not thought to be a driver of PTSD symptom change itself. Rather, it's a way to kind of boost these other very effective treatments and bring family members in. So that is the thinking there. It's just 2 sessions, so much briefer than CBCT, obviously. And the sessions are delivered to the family member alone. The reason that we did that was manyfold. One is just a practical consideration. It's much easier to just schedule with one individual and a clinician rather than 2. We also felt that family members might be more forthcoming about the challenges of living with and caring about someone with PTSD if the veteran wasn't present in the room. And then finally, from kind of a dissemination standpoint, we know that a lot of clinicians do not feel especially confident or comfortable in delivering dyadic treatments. Many of us didn't receive that kind of training in our graduate work or on postdoc or anything like that. To get really, rich supervised experience in couples and family work is the exception rather than the norm. And so we set up the BFI to be, just a one-on-one, feels like a very CBT-esque delivery system. And so hopefully that feels more comfortable on the provider end as well. The content of the BFI is largely psychoeducational, talking with the family member about the symptoms of PTSD and what individual PTSD treatment looks like. There's also some attention to reducing accommodation by the family member, which are sort of behaviors that family members engage in that, in the short term feel helpful to them and the patient often, but really kind of facilitate avoidance and in that way sustain the disorder in certain ways. And so a pilot study that we ran with the BFI found that veterans whose family members received the BFI were 50% less likely to drop out of their individual CPT or PE treatment relative to veterans whose family members didn't receive the BFI. So that was really encouraging to us, speaks to, the value of even these kinds of brief touch points with family members. So that, I present this not to say that the BFI is the only legitimate way to have sort of these briefer contacts with family members, but just to show you that it can be worthwhile, even a session or 2. And finally, I want to direct people to some handouts that the National Center for PTSD has developed. If you're not in a position to hold any sort of joint sessions, or your patient doesn't feel ready for that or interested in that, the National Center has developed these really nice handouts that you can print out for your patient and then hand to them. And they cover their information for loved ones about CPT, PE, EMDR, or written exposure therapy. Really nice, high quality information for the family members. So I'll end with sort of my 3 take-home points, and I'll go into more detail about each of these in terms of recommendations for providers when thinking about family inclusive care. The first recommendation is to make it standard as much as possible. I think we don't want to be relying on, as I said, individual clinicians to think of it, to mention family inclusive treatment, or certainly not for patients to bring it up themselves. Often patients are unsure if that's an appropriate request or if it's a possibility. Certainly within the VA, I've had veterans say to me, well, I didn't think I could, my partner's not a veteran, so how could they ever come in here with me to be seen in this way? So thinking about, are there ways that you can build family involvement into the fabric of your clinic or into your own kind of routine practice, so that you're not in a position of having to remember it independently or make judgments about which patient might or might not be open to it. Hopefully that 80% number sticks in your mind and you can think to yourself, anyone might be open. I can't predict. And so better to present it as an option and talk about it with all of my patients, rather than trying to do your own guesswork. Conversations, not questions. And by that, I mean, rather than asking as a simple yes or no, do you want family involvement in your care? Which I have seen even on an intake form as just a straight yes or no question, and there's sometimes no verbal follow-up to that. We would preferably be having a conversation with our patients, exploring with them what might family involvement mean to you. When I ask you about that, what are you thinking? What feels kind of like more than would be acceptable to you versus what does feel comfortable to you? How might it look? Trying to show them the range of what would be possible, and also establishing some comfort with them that you're going to respect any limitations that they want to set in terms of the degree of detail that you're going to be talking about with regard to their traumatic experience or whatever it might be. Trying to set the expectations and really help them understand what might be possible. And additionally, please, if you do make it your practice to ask at intake, which I would, recommend certainly as a starting point, I would encourage you to ask at other points throughout treatment as well. A couple of different studies now that we've run in different samples of veterans have shown a significant increase in willingness to involve family members over the course of trauma-focused treatment. So that even if you ask at intake and the patient declines at that time, it is still worth asking at other points throughout care, because their answer may have shifted as either they become more comfortable in their work with you, their symptoms decrease, whatever it may be. So please have it be, a thing that you continue to assess over time. And then finally, offering some options. As I've tried to make clear here, family involvement is a spectrum. It's not all or nothing, that it has to be a fully dyadic treatment of, many, many weeks, or it's not worth doing at all. So offering your patients some options for what that might look like, and being clear for yourself about what you feel competent to deliver, but also not discounting, even briefer forms of involvement. They can still be quite effective and valuable. So I have a few references there, and happy to hear any questions if folks have them. I'll stop sharing now.
Great. Thank you both so much. This was such a nice sort of combination of talks. That was fantastic. Given that we do have a few minutes, I don't know if Dr. Brenner, you didn't want to go back and talk about some of the treatment approaches that you're doing in your clinic.
Yes, absolutely. So I mistakenly thought I was at my time, so I'm going to revisit this current slide here. So really talking about, as I mentioned when I showed the slide before, with all of the different diagnoses that we're seeing, there are a number of evidence-based treatments that we recommend, and there are a number of treatment approaches that we recommend you can utilize different aspects of. Again, as I mentioned, one of the big barriers to care is the ability to engage in a consistent course of treatment. So we offer at home base, for example, a condensed treatment program. Different approaches that I would recommend. So traditional CBT is always going to be a very, very strong approach with these individuals. So incorporating behavior activation, which should be very focused on values, right? What is most important to this individual? What do they get meaning out of? What are the goals that they have for themselves? And then we're going to be utilizing traditional cognitive therapy. So identification of unhelpful thoughts, reappraisal of those thoughts, utilizing a thought record, very straightforward. We also have trauma-focused treatments, as Johanna mentioned, prolonged exposure, cognitive processing therapy, written exposure therapy, as well as a form of a moral injury treatment known as adaptive disclosure. This is a specific approach to targeting moral injury. Main transdiagnostic treatment that we also recommend is the unified protocol, which is a 12 to 16 session treatment that really incorporates cognitive restructuring with mindfulness and exposure-based approaches to treatment to address a wide-ranging variety of emotional disorders, including anxiety, depression, substance use, PTSD, and adjustment-related disorders. There's a very high rate of sleep impairment that we're seeing in this population. So really talking with them about CBTI, or cognitive behavioral therapy for insomnia. A recommendation that I often give is to download an app known as CBTI Coach, which is a great self-guided way of being able to monitor your sleep, be able to set an appropriate sleep schedule, and make adjustments to the behaviors that are interfering with sleep and prolonging some of the sleep challenges that we see. I want to highlight the different types of exposures that we emphasize as well. So specifically, we're highlighting emotion-focused exposures. Many of these individuals have what I often call emotional atrophy over the years. They have not had the opportunity to utilize and talk about certain emotions. So being able to target various emotions that they may be avoiding, that they may have compartmentalized or suppressed over the years, is one approach to treatment that we highly recommend. Interoceptive exposures are another approach. Interoceptive exposures being targeting our physiological sensations, purposefully bringing up certain experiences that we have inside. For example, for individuals with panic, we often have them do activities or exercises that mimic the feelings of panic, and then reteach themselves what emotions and what sensations are safe and what are indicators that they may be experiencing a panic attack. In vivo exposures are exposures which go along really nicely with behavioral activation. In vivo meaning in real life, where we are encouraging people to re-engage in activities they might be avoiding or doing, but kind of white knuckling their way through, right? So not really allowing themselves to experience the emotions and the distress that might come up. And then imaginal exposures are a very significant portion of our prolonged exposure protocol, which involves repetitive revisiting of a specific traumatic event for the purposes of habituating or getting used to and increasing the confidence and the ability to talk about the event while decreasing some of the emotional reactions that come along with it. So just wanted to take another moment to go over this slide. Thank you so much.
Great. Excellent. And so I put if you have any questions, again, please feel free to put them in the chat to me or raise your hand and I can call on you. You can certainly unmute and ask your question. I have a few though to get us started. My first question is really to both of you, but maybe Dr. Thompson-Hollands, given her sort of specific work in family involvement, is how do you determine sort of whether family members are kind of capable of engaging in treatment in sort of a positive and effective way, I guess? Are there some cases where this isn't maybe indicated? What you sort of mentioned that, but I was curious if you could talk about it.
Yeah, it's a great question. And it definitely comes up, right? Like some of our patients are, involved in relationships, either, romantic relationships or just an extended family member who's very critical and challenging or holds stigma themselves about mental health. And as I mentioned briefly at the beginning, those people can be very detrimental to our course of treatment with the individual. So what I will say is that for the most part, the veterans recognize that. They know, they might wish that their relationship with that person or that person's attitude toward them was different, but they've had enough experiences to know, this person, all they do is talk badly about therapy, or, they've blamed me a lot and said, just why don't you just get over it, or things like that. And so I think we can talk through choices with our patients directly and sort of explore and validate their wish that things were different with that person, while also holding like that might not be the right person to support you in this way. And let's explore if there's anyone else. I should say as well, I know I kept talking about family, but that's a feature of all of the research that's been done that has often limited to family members. But in principle, a close friend would also provide a great source of support for many people. So just because someone is married, their spouse doesn't have to be the one that's brought in. And I think that's really worth thinking through with them as well.
And I was going to add, when we talk about with the Special Operations Forces community, what we're really encouraging them to do, because there are so many barriers to getting them into care, we're often utilizing many of the supports to encourage them to be able to come in. And we utilize, especially with a lot of our testing, we'll say, is there a possibility that we can speak to your partner to get an idea of how they're experiencing your symptoms? And they'll often be very on board with that, because they recognize their own limitations and being able to really, truly identify and monitor their own symptoms. I just also wanted to highlight the research finding with Special Forces, the Special Operations Forces members, that found there's the inverse relationship between seeking support from those that you work with and having an increase in some of these symptoms. So we talk a lot with these individuals about unpacking what they've experienced with the appropriate people at the appropriate time. So that's really something that we're emphasizing with them as well, because often they'll come back and they'll just dump their trauma and the stress of what they've experienced on their family, and then the family doesn't have the appropriate resources or the skills to be able to manage some of this kind of traumatic sharing. So we really talk about, just to underscore, unpacking with the right person at the right time.
That's great. And another question that has come up before when I've been thinking about sort of caring for veteran service members and their families is how to sort of overcome some of the stigma of care, and how's that sort of coming along in this particular population. Any thoughts that you have of sort of helping people to overcome that? I'm assuming we might have some other clinicians on the call who aren't, maybe working in veteran specific places, but, could have access to that population who may not be sort of invested yet in care, and just curious to see what thoughts you guys had on that.
I'll start. So from my end, with the high performance that these individuals have, we're actually finding that a lot of the responsivity to treatment is when people in higher brass or higher positions are openly saying, I've sought treatment, or I'm going and talking about this. So there's, again, kind of relying on the community aspect and the brotherhood that they share, is that there is, a lot of the movement that we've seen in the willingness to seek treatment is around, oh, this person that I served with is willing to talk about these things, so I'm going to be more willing to. And I always say to providers, you want to approach them as a person first, right? Always start with, asking questions that get to who is the person that is sitting in front of you, rather than who are the symptoms that are sitting in front of you. And I find that is a really approachable way to get people to engage as well.
And I think Lauren mentioned several times, about connecting with the values of the individual. And often I think, getting back to this family element, connecting to, helping them to talk about, in a motivational interviewing type of framework, are you being, again, the parent that you want to be, the partner that you want to be, and connecting to those values about showing up for loved ones in the manner that they would want to, ideally. And even potentially, like, is this how would you want to model for your own children? If you're struggling, if they were having these experiences, would you want them to feel like they had to handle it alone and couldn't talk to anyone about it? Or, you can be that model of the higher brass person for them in that way. Yeah.
Very well said. And, I'm not seeing any questions yet, so I will ask you guys if you guys have any sort of additional thoughts before we wrap up, but please do, if you have a question, get it in now, because otherwise we may end a few minutes early to allow people a chance to do something before their next call. But anything, Dr. Brenner or Dr. Thompson-Hollands, you guys want to add with either questions to each other or thoughts that you guys have in doing this work?
I don't think anything to add at this point. It's been so wonderful to talk through all of this.
Great. Agreed. I think I just want to say, right, I think this was such a wonderful kind of no pun intended, but marriage of topics, because it really is so important that, like I said, with the special operations forces, that they have the support, they have a place they can really talk about some of this, and that the family side, that they're, learning the language and understanding what it is that their support, their person, their partner is also learning as well, and being able to have that kind of generalize across their life.
So important. There is a question from Ron in the chat, Lauren, about a citation for the unit support for special forces. So I don't know if you have a minute to pop that in the chat.
Yes, I'll pop that in the chat.
Or follow up with him over email. That would be great. I just want to echo what Cindy also just put in the chat, which is, as someone who used to work at home base and was very sad to leave to take on this position in the Center for Faculty Development, I just want to thank you all for the work that you're doing. I'm also the daughter of a veteran and just incredibly grateful that we have these wonderful resources out there and great research that is helping to sort of better understand how we can engage and support our veteran service members and their families. So incredibly grateful. So thank you all so much. And I guess we'll end here. Take care, everybody. Thank you.